Xerostomia is defined as a reduction in saliva flow. The reasons why a patient might have a reduction in saliva flow are going to be covered more in your saliva gland dysfunction resources. But xerostomia is something you're going to have come across in terms of the term already. You'll have talked about it when you're thinking about risk assessments for caries and periodontitis. So we know that having less saliva increases our risk of those things because saliva itself is a protective feature. The important thing to remember with the xerostomia is it in itself is not a condition. It is a symptom of another condition that's resulting in a reduction in saliva flow. There's lots of reasons for it, like I've said, that we're going to touch on in this video, but mostly you'll look at them in your resources. It might be because of a problem with the saliva gland itself, or it might be because the signals are not getting to the saliva gland to produce, or it might be because although the saliva gland has the capacity to produce its secretions, it doesn't have the raw ingredients to do it. We often see xerostomia in older people, but as you can see from this statement from the Oral Cancer Foundation, xerostomia, it's not a symptom of old age. However, as we age, we are more likely to experience or suffer from the conditions that cause xerostomia. So it's not just because you get it as you get older, but we are more likely to see it in older patients. So why do some patients experience xerostomia? Prescribed or recreational, for that matter, drugs is one of the main reasons. Now, it might be an individual drug itself. So we see that in antidepressants, antipsychotic medications, some cardiac drugs, things like antihistamines. So those on their own can cause a reduction in saliva flow. And certainly if you look in the BNF, the side effects of quite a few drugs, it will say dry mouth. But more commonly, we see xerostomia related to drugs because of polypharmacy. So the patient's just taking a lot of different medications. And again, this is more common in older people. Individually, those drugs may not cause xerostomia, but taking a lot of them together does seem to have that effect. So polypharmacy is what we call that. Radiotherapy, so previous radiotherapy for head and neck cancers, can cause significant damage to a saliva gland. They're quite sensitive tissues that are easily damaged. So if you pass radiation through them to get to whatever it is that needs, where the cancer is that needs treated, then that can cause permanent damage that can permanently knock out an entire saliva gland. Sjogren's syndrome is related to rheumatoid arthritis, which you can see on the other side. We're going to look at that more as you work through the resources. But Sjogren's syndrome is defined as reduced saliva flow and reduced flow from the lacrimal glands, which is our tear secretion. Diabetes, both diabetes mellitus that we most commonly deal with, and then also diabetes insipidus, often result in patients suffering from chronic dehydration. And if you have not enough water, then we're not going to be able to produce saliva properly. It's one of those raw ingredients I mentioned earlier. So chronic dehydration as a result of diabetes will certainly result in xerostomia, but just chronic dehydration in general, somebody who just doesn't consume enough water, common in elderly people and people in care homes, are going to struggle to produce enough saliva. Obviously, if you have a specific problem with the saliva gland or you've had surgery on a saliva gland, that could potentially reduce its productions. MS is a neurological condition. We'll look at it specifically later in the module, but the breakdown of neurological tissue that occurs in MS can result in the signals from the brain not getting to the saliva glands to produce to tell it to produce what it needs to produce. Immunological disease, so a disease of the immune system, like for example HIV, can also impact on our body's ability to produce saliva, because saliva is a protective factor. If we're not processing the signals that say to protect ourselves, then that could be a problem. And then one that many of you, if not all of you, will have experienced is actually xerostomia of psychogenic origin. So that means a physical manifestation of a psychological condition. So have you ever been really, really nervous or really, really anxious? Maybe it's because you've got a presentation to do. Maybe you've got an exam. Maybe you have to go on a first date. Something like that. Something that's really making you nervous. Maybe you're about to do a skydive. You will have experienced what feels like debilitating dry mouth. It's particularly annoying if you're going to need to speak. That is xerostomia of a psychogenic origin. Now, obviously, that's transient, and there's a specific reason for it. Somebody who suffers from a mental health disorder, perhaps chronic anxiety, might experience that more longer term. So, what does it look like? Well, xerostomia is diagnosed clinically by clinical presentation. So, it's not like you measure how much saliva somebody produces, and if it's under a certain amount, that classes as xerostomia, because everybody's saliva flow is different. It's subjective. So it's diagnosed by us or another healthcare professional looking in the patient's mouth and going, oh, that seems a bit dry. So if we're dealing with quite a mild case, the patient might actually not be that aware of it, particularly if it's happened over a long period of time. They might not realise that their mouth is supposed to not be that dry, that they're supposed to have more saliva than that. And it's not really till we look in their mouth that we think, oh, things look a bit dry. You do need to be conscious of that psychogenic origin, though. An awful lot of people who sit in our chair will be quite nervous. That might be causing their dry mouth. So you need to have a conversation with the patient about that. Once it progresses to moderate, the main place where you'll see symptoms will be on the patient's tongue. The tongue will be dry. And rather than being a sort of pinky colour, it'll be more red, just slightly redder than you would expect to see. Atrophy, the term atrophy means wasting. So we have to remember that the tongue is a group of considerable number of muscles. So if the tongue can't function properly because it's dry, then we start to see atrophy of those muscles. So the shape of the tongue can change. And then the dorsal surface, we will either see it be particularly wrinkled or a bit on the smooth side. So just deviating from what we would expect to see slightly. Then as we progress to severe, you're going to see more dramatic deviations. So the tongue will be smooth in terms of lack of papilla. So that generalised rough surface that we have from the folate papilla in particular to allow us to help us break down our food, they disappear and we're left with a smooth, shiny surface. Having said that, you will see fissures, so deep grooves that run either the full length or width of the tongue. Generally very inflamed, so a much brighter red, swollen type thing. And the patient can experience a sort of burning sensation on their tongue itself. From the mucous membranes, or buccal mucosa, vestibular mucosa, soft palate, pharynx, very dry, and that makes it shiny. And when you're examining the patient, it's sticky. So your gloved fingers will stick to it, or your mirror. Our lips are obviously an extension of the mucous membrane of our mouth, so they can also be very dry, cracked, fissured, bleeding, painful. We describe the saliva as rope-like, so that's that thick, stringy stuff. When you put your hand in your patient's mouth and you take it away and the saliva comes with it, or when they're talking and you can see stringy saliva. And then because the saliva is not there to clear away food, debris, plaque, that type of thing, also the patient's likely to experience halitosis where you're on that severe end. So these are all the things we're looking for to come to the conclusion that yes, your patient has the symptom of xerostomia. So how does it impact on the patient? Obviously that depends on the extent of the symptom, but it can vary dramatically, right up to really affecting somebody's quality of life. If you don't have enough saliva, you're going to struggle to eat. That can then lead to malnutrition. So simply not having enough saliva, I say simply, is not simple at all. It can make a person very ill. This person is likely to be ill anyway. That's why they've got the xerostomia. So it's a real vicious cycle. So difficulties eating, difficulties talking. If the person wears a denture or perhaps another prosthesis because maybe they've been a cancer patient, it can be very difficult to wear those. They either stick to the soft tissues or actually you can, particularly with an upper denture, you can see the opposite, and they lose the suction because it's the saliva, the moisture from the saliva helps form the suction across the palate to hold an upper denture in. So they can have a denture that's both sticking to their cheeks but not sticking to the roof of their mouth. So it can really, really impact on somebody's quality of life from that perspective. We rely on saliva to put our food into solution, which then allows us to taste it. If we can't dissolve the compounds within food that give us taste, we won't be able to taste it. And that can be really depressing. Obviously, we've mentioned already that we're an increased periodontal and caries risk, and you've looked at that a lot in the past. Also, increased risk of fungal infections. We've spoken about candidal infections earlier in this session. The saliva helps to keep everything in check. The candida that we naturally, healthily have in our mouth is helped keep in check with the antimicrobial properties of our saliva. So if we don't have that saliva, then that can easily become an overgrowth of candida. Similarly, bacterial infections, we've just not got the saliva there, the antibodies in our saliva perhaps, to help deal with infections. And particularly the saliva glands, the ducts that lead to our major salivary glands, the constant flow of saliva out of them stops anything getting in. But if those ducts are lying dry, then that's an opportunity for, again, normal commensal bacteria in the mouth to creep their way in and then potentially cause infection in the saliva glands themselves. Mucositis is inflammation of the mucous membranes. Now, this is experienced on the more severe end of xerostomia, and it's often in patients who are having or have had cancer treatments. It's very unpleasant. It's everything that you would expect from inflammation across the entirety of the mucous membranes of the mouth. So very red, swollen, atrophy, so breakdown of the tissues. If you think about your 5 cardinal signs of inflammation, so pain, redness, swelling, loss of function, and also heat. So all these unpleasant sensations in the mouth. Ulceration, pseudomembrane, so sloughing, really, really unpleasant. And that can be really, really hard for the patient. And it can make all the things that you want them to do to help keep their mouth healthy really difficult. So how do we help patients manage xerostomia? Well, we've said right at the beginning, this is a symptom of another condition. So the best thing we can do is try and manage what's causing the xerostomia. If this person is diabetic and they're having xerostomia, that would suggest that their diabetes control isn't perhaps as good as it should be. So they need to see their diabetes practitioner, probably nurse, to help deal with that. If it's related to a specific drug they're taking, is there any way that could be changed to a different drug that might not have the same impact? Again, speak to their GP. If this is chronic dehydration, can we advise the person on how they can increase their fluid intake? And that doesn't just mean saying to a patient, you need to drink more. If the patient's dehydrated to the extent where they're having issues with the saliva flow, they need more than that from you. They need a managed plan and ways that they can increase their fluid intake. So dealing with the cause that's resulting in the symptom of xerostomia would ultimately be the best option. That's not always possible, however. And it may be that the underlying condition, it's nothing we can do anything about. So maybe they've had that radiotherapy and it's permanently damaged their saliva glands, or maybe the polypharmacy is unavoidable. So in that situation, we have to manage the person living with xerostomia. So preventative advice is always going to be absolutely key. Optimal oral hygiene, and adjusting it to the patient's needs. Maybe they need a particularly soft toothbrush because they're suffering with pain, the burning mouth sensation, mucositis, things like that. Maybe they need to do what they're doing but more often. Maybe because of their high risk, they need to increase that to 3 times a day. As always, targeted to their needs. Diet advice is absolutely crucial. This person needs a sugar-free diet. That is difficult because oftentimes what people do when they've got a dry mouth is have something that increases their saliva flow, so a saliva stimulant. That is often something sugary. So sweeties, sit and soak on hard sweets. That will increase your saliva flow, but obviously there's a sugar issue there. So if that's all that they can do to find relief, they need to be using sugar-free sweeties every time. So getting that diet as sugar-free as possible, ideally completely free of free sugars. If the person is a smoker, they need to understand that that could also be contributing to their xerostomia. Unless they're a very heavy smoker, it's unlikely to be the only cause, but it could certainly be a contributing factor, a comorbidity. Alcohol use is not advisable in somebody with a dry mouth. They're already at a high risk of soft tissue lesions simply because of the trauma that's happening in their mouth. So limited, very limited, well below the maximum guidance from the government. In terms of something to help get the mouth wetter, we have two options. There's saliva stimulants and saliva replacements. So saliva stimulants are good for somebody who still has saliva gland function, but it's not as much as you would hope. If you have no saliva gland function, trying to stimulate it won't work. So in that case, you need a replacement. The saliva stimulants tend to be pastils or gels, something that you suck on. They're often quite sort of natural products, but you have to be careful of things like citric acid. Citric acid will definitely increase your saliva, so like lemons and limes. However, we don't want to be introducing more acid into an environment that's already at high risk of caries and erosion, so just be careful of ingredients like that. They can also be prescribed by a dentist or a doctor or oral med consultant. Saliva replacements are pretty viscous liquids and gels the person puts in their mouth to mimic what naturally produced saliva would do. Some patients like them, but oftentimes people don't find them very useful. You have to constantly be using them. So for those people, they may find simply regular sips of water or using a water spray because they may be reluctant to drink so much that they end up in the toilet all the time. And so an atomizer can help. Topical antimicrobials may be needed if there's a specific infection, so maybe the fungal or the bacterial infections that we mentioned before. Something like nystatin pastils for candidal overgrowth. We used to use chlorhexidine in patients with xerostomia. To be honest, we used to use chlorhexidine a lot. It was almost a wonder drug for a while. We've now realised that it's not very well retained in the mouth, so possibly not as useful as we thought. Also can be quite irritating, and we want to avoid that in tissues that are already irritated. So chlorhexidine is maybe not the best option anymore. Fluoride kind of comes back to prevention, doesn't it? These are the patients that need high fluoride toothpaste, your 2,800 or even your 5,000 parts per million. They're also the patient that one of the few patients that may benefit from a mouthwash, so a fluoride mouthwash, regularly throughout the day. Do make sure it's alcohol free though. As we've said, they're already at risk of soft tissue lesions, and alcohol can tend to be quite irritating. So an alcohol free fluoride mouthwash might help for these people. Fluoride varnish, lots of it regularly. You may need to get a prescription from the referring dentist for that if it's a prescription only medicine. Ice cubes can be quite good for patients who don't want to constantly be sipping on water because it can just slowly melt in the mouth. They may If the person's very dry, though, they might find they stick to their tissues, which would be uncomfortable. So it's an option that somebody can try. Sugar-free chewing gum is good for some people who have some saliva flow. So maybe the mild to moderate end of things. If you have really limited saliva flow, the chewing gum's going to stick to the tissues. But if you have a little bit of saliva flow left, chewing will help because your brain thinks you're about to eat something. So it will produce saliva. And then at the bottom there, I've put regular recall. It's so important for us to see these patients regularly. They're really high risk for oral disease, but also other diseases, and we may be the person who sees them most regularly. The patient may not be managing the oral hygiene or other preventative advice as best as we would like for reasons completely out with their control. So maybe we need to see them really regularly to help support that as well. So these might be somebody that you see every 4, 6, 8, 12 weeks. This is a really regular thing for us. We need to keep supporting them. We need to monitor the progression of this symptom of xerostomia, and we need to provide them with as much advice and actual treatment as we can for them. So xerostomia is something you're going to see, and particularly if we're working in any kind of special care environment or maybe in an environment with lots of elderly people, you're probably going to see it quite frequently. But always think, right, this is a symptom of something else. What's going on here? And if this patient has nothing else in their medical history, they're not aware of anything, and you can't pinpoint what's causing this, then that's a red flag. This is a patient that may well need to see their GP because maybe there is something going on that they're not aware of. But by us saying, your mouth's very dry, are you aware of that? Have you ever mentioned it to your doctor because it might be caused by something else? Just flagging that up to them may be the point that whatever it is that's causing this gets recognised.